Well, hello, friends. It's another installment of Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. I am Kendrick Curry, one of your co hosts. I'm from the Pennsylvania Avenue Baptist Church in Washington, D.C. And we also have another co host in terms of a sponsor in terms of MOTEP, which is the Minority Organ Tissue Transplant and Education Program. We are excited today about what is going to happen. We're going to talk about the 5 stages of kidney disease, and we're going to bring on some dynamic speakers like Dr. Joseph Keith Melanson, who is a distinguished transplant surgeon and medical leader in Washington, D.C. He's the chief of Transplant Institute and Division of Transplant Surgery at George Washington University Hospital. He's a professor of surgery, and he is the medical director for the Ron and Joy Paul Kidney Center, a nonprofit dedicated to community outreach and research around kidney health. So we welcome Dr. Joseph Keith Melanson, and we also have the distinguished and the dynamic Clive Callender from MOTEP, which again is the Minority Organ Tissue Transplant Education Program. And we're going to have a wonderful program today as Dr. Melanson gives us a presentation on those 5 stages of kidney disease. Welcome, Dr. Callender and Dr. Melanson.
Thank you, Dr. Curry. It's been a long time, but I'm so happy that
Glad we're back.
the gang is back together. I see Dr. Calendar, and I see Dr. Calendar smiling. I saw that his Alphas won the step show at Howard's homecoming, so
Oh,
he
Lord.
got such a big smile on his face. Yeah, so congratulations, Dr. Calendar. Um,
Right.
Dr. Reverend Curry was giving you congratulations before you got on here today. But anyway, we're going to talk about kidney disease, and this is a talk that I've given numerous times, but I'm always surprised that people still need to know this information. Even when we go to dialysis centers, people don't understand about the progression of kidney disease. So it's very, very important that patients find out very early. This is something I learned from you, Dr. Calendar, a very long time ago, that you got to go into the community and you have to test people and you have to educate them. The power is in education. You can't change people's behaviors until they know what behaviors to change. So the only way to do that is through education. And I'm hoping that today we will get a lot of good questions from the community because this is so important. I'm a transplant surgeon, and so many people I transplant, they started off with a form of kidney disease that could have been treated and for whatever reason was not. So we'll go through all the stages. And like I said, we're going to leave lots of time at the end so that we can have a robust discussion. All right. So the title of this talk is What You Should Know About the Risk of Kidney Disease. All right. So in kidney disease, ethnicity matters. As we do know, there's no such thing as race, right? Race is a social construct, but ethnicity does matter. Where you come from, who were your parents, grandparents, great grandparents, so on and so forth. That is important because diseases can be passed on in generations. And there are groups of people that have very similar diseases because the environment that they come from is similar. The diets that they eat are similar. So these sorts of things are definitely a problem in groups of people. And we being African Americans, we have a lot more problems with kidney disease, right? We are sometimes even more than 4 to 5 times more likely to have kidney disease than what is oftentimes used as the normative in this country, which are white people of European descent. So black people are 4 to 5 times more likely to have kidney disease. We're not a different race, but we are a different ethnic group. And this ethnic group has a problem insofar as kidney disease. But we're not the only ones. Almost every other ethnic group that would classify different from being white has more kidney disease. Native Americans have more kidney disease. Hispanic Americans have more kidney disease. Everybody, including Asians, oftentimes Asians are healthier than other Americans, but in kidney disease, Asian Americans actually have more kidney disease. Now we're on top, followed by Native Americans, 2 to 3 times more, followed by Hispanics, they're about 2.5 times more, and then Asians are about 1.5 times more than white patients. But we have a huge problem, and black people need to understand that. So, what does that mean? That means that you need to be, if you're African American, you need to be even more mindful of the sort of things that lead to kidney disease. I talk about this all the time, but what are the top 3 risk factors? Obesity, high blood pressure, and diabetes, right? Those are the things. And most of the times, people with kidney disease have a combination of those things: obesity plus diabetes plus hypertension, right? So if you're African American and you fall into all 3 or one of those 3 categories, your risk is even higher. So this is a truth. And if you are blindly going through life and not thinking, oh, wow, I wonder if I have kidney disease, then you are not being smart with your health. Next slide. Yeah, now this is a slide that I love because this is such an important quote from an idol of mine and an idol, I think, of most Americans, Martin Luther King. He said, of all the forms of inequity, injustice in health is the most shocking and the most inhumane. Just the other day, I saw the great Barack Obama giving a talk. And in his talk, he said that what he's most proud of is Obamacare, as he should be, because 50 million more Americans have health insurance as a result of that one bill. 50 million people. And when you start to factor in how many lives are saved as a result of that, we're talking in the millions of lives saved. So, one of the biggest problems we have in this country is access to care. And it's, I believe, embarrassing that not only the richest country in the world, but the richest country the world has ever seen has such poor access to care for a large percentage of people. It's just mind-boggling that this is not more of a political issue. I haven't even heard it discussed in this political campaign, or at least not much. But access to care continues to be a problem, and that's one of the reasons why we have such high incidences of kidney disease and diabetes and high blood pressure, so on and so forth. But let's not let our people off the hook, because we have a big problem, right? And this happens in many cultures. Every culture has its comfort food, right? As you guys have heard many times on this show, I am from Louisiana, the great state of Louisiana, the greatest of states, right? And my culture has supplied the world with, I believe, the best food ever. If you've ever been to southern Louisiana, you've ever been to New Orleans, and you've had any of the cuisine, it is delicious, to say the least. But it can also be very, very unhealthy. And so we, as Black people, need to be mindful of the fact that a lot of the food we grew up eating that we love can also be very, very bad for us. Fried food is can be delicious, can be very much delicious, but it's not particularly healthy. So we need to change our diets, right? It doesn't mean that you can't have food that's good, because you can spice up almost anything, right? Where I come from, we love our food to be very high in spice and pepper and so forth. But it doesn't mean that you only can put pepper on fried food. I mean, it can be placed on salads as well. So the point is, once you realize, actually, to be honest, even before you realize you got a problem, you can be practicing preventative medicine by making sure that you eat a diet that is healthier, right? Again, it's okay to cheat every now and again and to have cheat days or have a dessert, once a week or whatnot. But the idea that comfort food is consumed so regularly is not healthy. Look, let me tell you, growing up in Louisiana, I used to get so excited at all of the big holidays, uh, Easter and Christmas and Thanksgiving, because that meant that my grandmother would be making her special dishes, right? But now, I mean, that I was in Louisiana less than a year ago in my hometown, and there's a restaurant that all the special dishes my grandmother used to make just 3 times a year, you can go and have at lunch every day, right? So talking about cornbread dressing, oyster dressing, rice dressing, stuffed ham, pork chop, all the stuff that we would have just 3 times a year, you can have every day. That's not what those foods were meant to do to be, right? Those were supposed to be special occasion foods, right? And people think Tuesday is a special occasion. You know what I mean? So we got to get people to, we got to disabuse people of the notion that they need comfort food every day. It's okay now and again, but not every day. So um, food that's high in sodium and preservatives. That's the other thing. It's not only that the comfort foods are being consumed, the ingredients that are being used for the comfort foods have changed. And if you've ever read anything online about how the meat in this country is now so grown in a way where there are a lot of antibiotics and steroids utilized in the poultry and in the beef industry that were not used when I was a kid. So it's not just the comfort foods, but the ingredients have changed, right? I always tell people, if you take an apple, if you go to a store and buy an apple and you put it out on your table, and 3 to 4 weeks later that apple still looks nice and red and juicy, something's wrong with that apple. All right. So it's not supposed to look nice and red and ripe for a month after it's picked, right? Something's wrong. The something is they are using some artificial things to keep those apples looking that way. So we need to be mindful of what we put in our bodies. We should be going to farmers markets and buying meat from the local butcher if there's one available, because getting fresh food is a big part of trying to make yourself healthy. And look, I'll just put it to you this way. Think about people that have really exquisite taste in what type of jewelry they want to buy, or what type of clothing they want to buy, or what type of automobile. All these things we might take a lot of time in tailoring to our taste. Well, we should do the same things with our bodies. The same patients that will tell me they don't have money to buy a certain medication or to get a membership of a gym are buying cigarettes. And I remember when my grandmother stopped smoking Camel cigarettes in the 70s, it was because a carton of Camel cigarettes had gone up to $5 for a carton of 12 packs. And a pack of or of any cigarettes, a pack of cigarettes today, one pack is about $20, right? So people find money for things that destroys their health and have trouble finding money for things that preserve their health. And we need to be thinking differently, because nothing is more important than our health. All right. So finally, Dr. Mawson's getting to the talk, the 5 stages of kidney disease. So what is so important about what I'm going to talk about today is that the early stages of kidney disease are reversible. So just because you have kidney disease, it doesn't mean it's the end of the world if it's caught early. And that's the key. It needs to be caught early, and then whatever caused the disease needs to be reversed. So that's why knowing what stage you're in, or if you're in any of these stages, is so important. Okay, so quickly I'm gonna review them here, and then I'll go through each one individually. All right, stage one, and this is important for you to understand. Most people would never know they have kidney disease when they're in stage one, because your kidney function by blood test is normal. Your kidney function is normal. I'm going to explain to you how you would diagnose it, but it's going to be hard to catch stage one kidney disease. And it's almost as hard, equally as hard, to catch stage two. So for the first two stages, most patients, even if they've gotten a blood test by a doctor, would not be diagnosed because their kidney function by the little computer printout says that they are normal, right? So it's important for you to understand what you need to be looking for and what you should be asking your doctor in order to be diagnosed in the first two stages. By stage three, this is when most people that have a doctor that's going and getting a yearly checkup, this is where they get diagnosed. Stage three, right? And as you might imagine, three is worse than one or two. So when you're getting diagnosed at stage three, you've got a major issue, right? Because the body's magical, right? The body will adapt. Our bodies are wonderful things, and you can get a lot of damage, and the body will adapt as long as it can, and until it can't adapt anymore. And that's when you get to stage three. Your body's been making up for the damage for a long time, and then all of a sudden, now you start to see an issue, and that's when most doctors will diagnose people with kidney disease. By the time you get to stage four, you have a pretty severe problem, because now you're at the point really of no return. Only a matter of time before you get to stage five. So that's why going from three to four is so important. You want to get diagnosed before them. Before then. Now, stage four doesn't mean all hope is lost. It just means that you are never going to get rid of the damage that you already have. So you can stabilize it at stage four, but reversing it is not likely unless there was some sort of misdiagnosis. And then stage five is when most people will start dialysis or start to be evaluated for a transplant, and that's what we call end stage renal disease. But okay, let's go through the stages. So stage one, the only way you're going to diagnose stage one, like I said, the blood test is not going to do it, because by blood work you're going to have normal kidney function. What you have to find, or someone has to find, is that you are spilling protein in your urine, right? And it's a cheap test. It's a little urine dipstick. It's a very inexpensive test, but it can be life altering, because if you're spilling protein in your urine, you want to get it checked out. Now, that doesn't mean that it's pathologic, right? So there are people that are normal that are going to intermittently spill protein in their urine if they have normal kidney function. So sometimes I think doctors are too dismissive of people that have protein in their urine, because the doctors are correct. It can be normal, but it's not necessarily normal, right? So if you get diagnosed with having too much protein in your urine, you need to go get it checked out. You need to, a specialist needs to look at what's going on in your life and say, okay, we got a problem here, right? Or we may have a problem here. And the only way, the only type of doctor that should be giving you that advice is a kidney doctor. That's called a nephrologist. Now, it's possible, like let's say you have a primary care doctor and you have an increase in protein in your urine, and you ran a marathon the day before. Okay, well, that doctor is going to tell you the right thing. That doctor is going to say, okay, all right, well, drink a lot of water. We'll get a new test next week, and don't run for the next week. And then you go back to the doctor, you get a new urinalysis, and there's no protein in your urine. Okay, that's understandable. That makes sense. But What I'm talking about is you get a test, it's positive. You repeat it after drinking water, after avoiding a big Houston size steak, that Dr. Curry, Reverend Curry knows about. You didn't have a gigantic Houston size steak. You didn't run a marathon. You repeated the test 2 or 3 times, and you still have protein in your urine, even though your kidney function is normal. All right, that's proteinuria. So then again, it may be a normal variant, but now you need to go see a specialist, and that is a kidney doctor. Okay. Now, that would be stage 1. Now, stage 2 is similar because stage 2 also, your kidney function can look normal. And what do I mean by that? What I mean by that is a lot of the tests for kidney function stop at a certain GFR. What is GFR? GFR stands for glomerular filtration rate. And what that means is the little engine inside your kidneys is working at a certain rate. And you can estimate someone's GFR by their size and how much creatinine is in their blood, because creatinine is a normal breakdown product of the protein that you digest and the protein that's in your body. So if your GFR is 60, which is a lot of blood tests kind of cut out at 60. In other words, they'll go up and up and up. They'll get to 60 and they'll say, oh, it's above 60, which is fine because being above 60 is good, but it's not necessarily normal. Meaning, the younger you are, the higher your GFR should be, right? So if you're 30 years old, your GFR should be 100, right? So your GFR should be 100. The test said you're above 60, you're good. Not necessarily, particularly in comparison. What I mean by that is what you should be doing as a good consumer of healthcare is every year you should be looking at your tests from the previous year and seeing how they line up, right? A normal hemoglobin for a 30-year-old is 14. So the year before, your hemoglobin was 17, and then this year your hemoglobin is 12. Your doctor might say, oh, your hemoglobin's 12. It's a little low, nothing to worry about. But the year before, you were 17, right? Same thing with GFR. Your GFR was 100, and the next year it's 70. 70, most tests will say is normal, but you were 100 the year before. These changes, this dynamic is very, very important. So as a good consumer of healthcare, you want to be mindful of not only your tests year to year, but year from year, right? You want to compare them and see if there's any major changes. But once again, stage 2, most significant issue is protein in the urine, which is why we send the team out into the community and we test people for early kidney disease. That's what we're looking for. We're looking for protein in the urine, because protein in the urine should not be there. And like I said, there can be variants that are normal, but you must be concerned when you see protein in the urine. Okay, next stage. Stage 3. Now, this is when most people that see a doctor regularly will be diagnosed. And the reason they get diagnosed is this is the first time that the blood test will obviously show that there's a decrease in your kidney function. There are 2 stages of stage 3. There are 2 parts. There's an early stage 3 and a late stage 3. But basically, by the time you get to stage 3, what's happening is your GFR by blood test has decreased. And this will alert the doctor that something is wrong. And usually by this point, you will go and see a kidney doctor. Now, what will a kidney doctor focus on? The kidney doctor will focus on, what's causing this, right? There are a lot, even though I kind of mentioned the 3 most common causes of kidney disease, there are lots of things that can cause kidney disease. Everything from lupus to something we call FSGS. There's a lot of things that need to be diagnosed or that may need to be diagnosed. And sometimes that will necessitate the kidney doctor getting a biopsy of your kidney or more blood tests. But the point is, once you get to stage 3, even before, to be honest, if you get diagnosed earlier, you should go and see a kidney doctor, a nephrologist, and they are going to do more extensive tests to figure out what's going on. Now, once they diagnose you, and again, particularly if you fall in one of those 3 main areas, what you need to do is you need to correct the problem, right? So the most common cause of diabetes in this country is obesity, right? So if you have newly diagnosed diabetes or diabetic, or even if you have what's called metabolic syndrome, and you really have what's called pre-diabetes, right? So pre-diabetes means you're not at the point where you need to be put on insulin, but your sugar is consistently high because fatty tissue just doesn't use sugar like it should, right? Muscle is really good at utilizing sugar, right? We're made to be muscular, right? If you go back hundreds and hundreds of years ago, people were not overweight like they are today. It was rare to see someone that was obese. Now we are more commonly obese than we're not than non-obese, right? So the fact that we're putting all this strain on our bodies and we have all this tissue that's metabolically not supposed to be there, right? From an evolutionary point of view, our bodies don't know what to do with all this fat because we were not created to have a lot of fat, right? Humans were created to be lean. So the fact that we have more fatty tissue means that we're more likely to become diabetic. So if you're more likely to become diabetic, or you've already started down the path towards diabetes, it's a simple fix. You got to lose weight. You got to exercise more. You got to eat healthier. You got to decrease the intake of glucose in your diet. I realize that we're going into Halloween where everybody gets a little glucose surge, but we have to be mindful of these things in order to make our health better. So stage 3 is major. You absolutely positively need to be under the care of a kidney doctor. If you have high blood pressure, you got to get your blood pressure under control. If you have diabetes, you got to get your blood sugar under control. If you're obese, you have got to get your weight under control. All right, stage 4. Stage 4 is the point of no return, in the sense that you're not going to reverse stage 4 all the way back to stage 3, stage 2, stage 1. However, what you can do is stabilize stage 4. So I've seen patients, and this is true, that have stayed in stage 4 for years, right? And how did they do that? They did it by being very mindful of their diet and decreasing their intake of red meat, right? So there are things you can do that will stabilize your kidney function. And it's very beneficial, right? Because you can stay in stage 4 and stay away from dialysis for a long time if you drastically change your lifestyle. But again, you absolutely must be under the care of a kidney doctor, and you got to be careful of a lot of other things like medicines you take, right? When you have kidney problems, you need to be careful in certain high blood pressure medicines, certain diabetes medicines, certain liver medicine. Like people might take medicine for high lipids, like hyperlipidemia. Your cholesterol is high. Well, these things can affect your liver. It can affect your kidney. So everything needs to be under the care of your specific kidney doctor. Everything needs to pass by him, not just your primary care doctor. You need a kidney doctor. And now stage 5. Yeah, unfortunately, when most patients get to stage 5, they're either going to be on dialysis or they need a kidney transplant. Now, these things need to be handled by professionals because untreated stage 5 kidney disease can lead quickly to death, right? Sometimes this is when people first get diagnosed, right? First get diagnosed. They don't have the care of a doctor. They're not seeing a doctor. They're going into stage 1, then stage 2, 3, 4, 5 kidney disease. They don't even know it. They don't even know their blood pressure is high because they're not seeing a doctor. They're not checking their blood pressure. So what happens to a person like that? They show up in the emergency room in kidney failure. They can barely breathe. their lower extremities are very swollen. Um, they are literally dying. They're really um, hours, if not days, away from death. And they go into the emergency room and they get there. Someone takes a blood test and realizes they're in kidney failure. They immediately put in a dialysis catheter and start dialysis, and that saves their lives. I've had patients who went to the emergency room, started emergency dialysis, and over the course of the next week or so, lost 30 to 40 pounds just because that's how much extra fluid was on their bodies because their kidneys were not working well. So once you get to stage 5, it's a very, very dangerous situation, and you need to be on dialysis. You need to be receiving a kidney transplant. All right, so Reverend Curry, we can open it up.
Yeah.
To questions.
Yeah, we have some excellent couple of questions that are already in the chat, and I know Dr. Callender has some, and I have some, and I like to start with those in the chat and encourage those that are listening. If you would please, put your questions in the chat. The first one is a good question based on your presentation, Dr. Melanson, which was excellent. It says, I'm in stage 4 with kidney disease, and I'm related. He's anemic, and there's protein in the urine. Should he incorporate whey isolate protein powder in his meals?
Yeah, so people ask questions like this all the time, and it is important that you avoid like red meat, right? So it's okay to still get protein in your diet, particularly like protein that comes from vegetables, so or even some dairy. So yeah, I think it's fine to take protein powder like that in small amounts, particularly if you're avoiding red meat. So you want lean meats. You want to, yes, take in protein, but make sure you're not overdoing it. The best way to determine what's going on is every time you're going to see your kidney doctor, they're testing your blood, and they will tell you what things are looking like. What's your phosphate levels? What's your potassium levels? What's your protein levels? So in general, that it's okay to use whey protein, but you should be changing your diet to avoid some of the other more dangerous types of protein
Yeah.
that are in red meat.
What about is there an over-the-counter protein test, over-the-counter test for protein in the urine, proteinuria?
Yeah, yeah, you can. Yeah, in any drugstore, you can get a little the urine dipstick, which is very inexpensive. And usually, what they will do is you put a little bit of urine in a cup, and then you take the dipstick and you dip it, and then the color will change, and it'll tell you if you have protein in the urine. You can also find out about glucose in the urine, which
Right.
although I didn't mention this, one of the ways to tell if you're becoming diabetic is if you have glucose in your urine, right? And
Mhm.
that's also a bad sign. So glucose or protein, you should not have in your urine, and if you have it, then something's wrong.
Okay. So you said the first 3 uh, phases are generally reversible. The latter 2 is much more difficult, particularly if you get to 5, it's next to impossible. Um, what advice would you give to someone that's at around a 3 that does not show up with protein in the urine, but is just generally eats well? Um, what would you say to a
Yeah, so you
person like
think
that?
this person does not have proteinuria. It's the blood test says the GFR has just come down. Okay, so what I would start by telling that person, okay, let's try to figure out why your GFR has come down. Why do you have something injuring your kidney? Because that's not normal, right? So again, like I said earlier, it's usually going to be high blood pressure, diabetes, not always. But if
Mhm.
it's the easy stuff, they're overweight, They don't exercise enough. They may be eating well, but um, they still have high blood pressure and or diabetes.
Right.
That's got to get fixed, right? So I would say, all right, you need to have a blood pressure cuff. You need to be checking your blood pressure uh, at least every day, maybe twice a day. We got to get your blood pressure under control, tight control, right?
Yeah.
So remember, high blood pressure is a number, the top number 140 or higher, bottom number above 80, right?
80.
So
Yeah.
if you got something going on with your GFR, we're going to get tight on that. We're going to say, all right, let's get that top number, about 130, not above 130. Let's get that bottom number not touching 80, right?
That's right.
We want to tighten up the blood pressure. We're going to check you and see, because you may not have real diabetes, because diabetes is going to be there's a very specific diagnosis for diabetes. We do a hemoglobin A1C, and that hemoglobin A1C needs to be above 6, right? So if the hemoglobin A1C is above 6, then they're going to do a more specific glucose tolerance test and see if that's abnormal. All right, both of those things have to be abnormal to be a diabetic, right?
Right.
But there's a wiggle room there. You can be pre-diabetic. You can have metabolic syndrome, and that means your glucose metabolism is not normal. You may not be all the way to being a diabetic, or you definitely don't need insulin, but you're right in that range. If you're there, then you got to get that better, right? So somebody has a hemoglobin A1C of around 6, I'm going to say you got to get that down to 5, right? I've had this happen with members of my own family. I'm like, this is causing you a problem. Everybody's bodies are going to be sensitive at a different range. So for you got to get that hemoglobin A1C down to 5. Usually that's going to be done by changing the diet. So even though you eat a healthy diet, you still have to be mindful to decrease the amount of sugar, to decrease the amount of carbs, white rice, white bread, all that stuff that that gives you a lot of carbohydrates. And you're gonna, more importantly, you got to increase your activity, right?
That part.
That's gonna be walking, exercising. And here's another kicker. And Dr. Callender is a big proponent of this: drinking water.
Mm-hmm.
You got to understand, our metabolism improves when we drink water.
Right.
So the more water you drink, I remember on this show, I said, I had incorporated something in my diet that I now do. When I go to a restaurant, first thing I do is I drink water.
Drink water. Yeah.
Drink water. So those are the things that I would have somebody do, Reverend Curry. I'll ask Dr. Callender if he wants to add anything, but you got to figure out why you have that diagnosis or whomever, and then you got to fix what got you there.
Yeah. Dr. Callender?
Yeah, I would only add that one of the things that complicates the problem is that the disease entities that you mentioned are asymptomatic. If you have hypertension, there are no symptoms. If you have diabetes, there are no symptoms. And so the person who has that kind of situation is expecting to have symptoms, but there are no symptoms. And so that makes it difficult to diagnose. But when it is diagnosed, it's important to recognize that the changes that you mentioned are so important. The normalizing of the blood pressure, the normalizing of the blood sugar, and the exercise, and of course, not to leave out good old meditation, which I always add to all of the other aspects of the therapies.
Well, there's another question in the chat that this sort of ties into, and it says, my doctor told me my kidneys are about 60%, and she wanted to know whether or not she should worry, but she didn't really understand why. 60% is about right at, if she's talking about GFR, right about that 3 range,
Right.
And that's right at that sweet spot, if you will, for reversal.
Right. And I think, and this is one of the mistakes I think we make as doctors, is we kind of mollify the patients, and we might mention something, but I don't think we emphasize it enough. right?
Sure.
60% is a problem, right? So I would be telling that patient, hey, your kidney function is compromised, right? You need to be mindful of that, and you need to be doing some lifestyle changes, right? And so it gets back to the discussion we just had. So I think, and this happens with obesity. The patient, the doctor will say, yeah, you're a little overweight, or oh, your blood pressure is running a little high. And I think with the doctor not seeming alarmed, it makes the patients go, okay, yeah. Because I will see them sometimes, and I'll say, oh wow, oh, your blood pressure is high, and they're like, yeah, my doctor said it's a little high, as if that's not an issue. No.
Yeah, like that's okay.
Yeah. And so
It's not okay.
Right, it's not okay. I mean, this, like I said, I just went through this, right? 3 is going to lead to 4. 4 is going to lead to 5, right? Unless you're reversing. So for her, the alarm needs to go off, and she needs to be thinking, what can I do to start reversing from stage 3 to stage 2? Because what you don't want is just continue doing as you're doing, because what you're doing right now, whatever it is going to get you to stage 4.
That's right.
So that the alarm needs to go off.
Yeah. Well, there's another question related to the blood pressure question, and I'm gonna tie it into one that I have as well. It says, "What's the best medication for high blood pressure based on ethnicity?" And I also wanted you to speak to, in light of blood pressure, in light of diabetes, what's the role that inflammation plays? Because inflammation is also very important for those with diabetes as well as blood pressure. How does that all work together? So best medication, and then anything you can speak to with regard to inflammation as it relates to diabetes or high blood pressure.
2 great and controversial questions. So thanks for that, Dr. Curry. I appreciate that. So first, let's deal with the blood pressure medicine, because that was Dr. Calendar will know this, but years ago there was a very controversial study that said what blood pressure medicine was best for Black patients, and the answer is there is no specific best medicine for Black patients or white patients or whatever. It really depends on what the issue is, right? So, and the issue can be varied, and it can group. You can have subgroups that they all have the same sort of issues, but it really depends, right? Because if your problem is you're holding on to too much fluid, well, then a medicine that causes you to get rid of fluid, called a diuretic, is going to be the best medicine for you, right? And so many African American patients will respond very well to some sort of diuretic. That's either going to be like a Lasix, or which is called furosemide, or hydrochlorothiazide or thiazide. So these things oftentimes work better. But to be honest, like I said, it just depends on the patient. And so here's what my answer would be. My answer is, I actually don't know. But here's what we should do. And what we should do is try a series of medicines if the first one we try does not work well. Because here is the rub. The rub is patients often will go to a doctor with high blood pressure, get a medicine, and the medicine either doesn't work well for them, or they have a side effect that they don't like. And therefore, they just stop. Because like Dr. Calendar said, the blood pressure is not symptomatic. The treatment is symptomatic, right?
That's right. That's right.
And think about it. You understand this, Reverend Curry. For young men, the number one symptom is impotence.
That's right.
So guess what? You give a young man a medicine that makes him impotent. Guess what he does?
He's not taking that unless he asks you for another prescription.
Right. Exactly. So the point is, what the doctors should be doing, and the good primary care doctors do this, you should tell the patient in advance, this is what could happen. If this happens, come back, we'll switch you out, and we'll try a different medicine. So it's not so much what medicine is the best, it's that you need to be open-minded to know that whatever you start with, there could be a different method, because there's a lot of different options. And then just to answer your second part about
wait, before you go to the second part, can you add to this other part of the question? I know I'm breaking them up, but somebody asked specifically about water pills causing dehydration and that not being good for your kidneys. Water pills as it relates to the whole blood pressure medication piece.
Right. No, that is a good point, and that's true. If you take too much of the water pill, you can lead to dehydration, and dehydration can make your kidney function
Right.
decrease. So that is absolutely true. However, what people sometimes don't understand is sometimes you want both things going on at the same time, right? So you're going to tell the patient, I know it doesn't make intuitive sense, but I'm giving you a water pill, but I want you to drink more water, right? Because where you're giving them the pill because you're pushing the water out of their body, which is going to help their blood pressure, but you're getting them to drink the water for all the good reasons that we talked about earlier, right? So they're flushing the water through their system. So you shouldn't decrease your intake, even though the doctors told you they need to put you on a fluid pill. And I think that's what happens to people. They stop drinking because somebody's told them they're fluid overloaded, and then they become dehydrated because they're on a fluid pill. So
Okay.
that's what can happen. And then getting to the inflammation point, and I think that's a very good point. There have been some great studies, and that's where you get into epigenetics and stuff that Dr. Callan did a lot about, of inflammation and stress and some of these diseases. And that's really, when you start thinking, why are Black people more likely to develop like high blood pressure? And I'm talking about recalcitrant high blood pressure. Young African American men sometimes have horrible high blood pressure where they're on like 5 medications and it's still not under control. And what the studies have shown is that maybe some of this is inflammation, like what your questioning is leading to, Dr. Curry, and stress, right? Some of the stressors of poverty and the social determinants of health and racism and prejudice, these things, cause not only one generation, but it goes from generation to generation. And there's good studies showing that that's part of what's going on in our community. So, like Dr. Calendar said, some of what you should be doing is de-stressing. And that's one of the areas. Like a lot of times I'm very suspicious of homeopathic sort of cures, but this is something that the homeopathic medicine, I think, I don't care if it's turmeric or whatever you call out, whatever anti-inflammatory you like, does make sense. But meditation, praying, going to church, or whatever your hobby is, anything that de-stresses you will tend to make you have lower blood pressure. Like people talk about fishing. If you like to fishing, you take the blood pressure of a person before they go on a fishing trip and after fish, and their blood pressure comes down because they're doing something they love to do and they get into their happy space. For me, golf, so it whatever it is, anti-inflammatories are good, and numerous studies, even like I said, the homeopathic stuff has been shown in real scientific journals, has been shown to work.
Well, Dr. Callender, I want you to weigh in on this as well. This next question is pretty interesting. It talks about metformin on dealing with diabetes, and is metformin not a culprit to chronic kidney disease? Metformin has been shown to be very hard on kidneys, but you're trying to reduce the diabetes, or the sugar levels, A1C, but at the same time, metformin, a specific drug, is difficult when you start to deal with this whole idea around something being hard on the kidneys and kidney disease.
Well, Dr. Melanson, I can let you know that number one, metformin is a good drug for diabetes, but I think it is important that the person who's on this medication is also managed by a nephrologist so that they can monitor the kidney function. Because, one of the things that I thought was wonderful the way Dr. Melanson answered is to recognize that, yes, there is no single drug that is the one drug that will work for everyone. There are drugs, multiple drugs that will work, but the most important thing about it is if you have side effects, that you let your doctor know so they can put you on appropriate drug. Right now we have about at least 20 drugs that can be used to modify the blood pressure and get the blood pressure under control. There's even a recent study that looks at using 3 antihypertensives, but using low doses of all 3 of them so that you don't get any side effects. The other aspect of medical care that you mentioned earlier is access. And one of the things that I fear is that not infrequently, after the patients have side effects, they often can't find a doctor.
That's
And,
right.
and so this is an aspect of it that we have to put on the table as well. That sometimes the doctor or the doctor's assistant is not available, and so you've got a side effect, and you don't know what to do about the side effect. And so therefore, what do? As you mentioned, they stop the medication, but
That's right.
the cause, the root cause, is still there. And so I think that the only other thing I would mention, because I must add that Dr. Melanson, you've exceeded your great deeds of the past. This is one of your best programs I've ever heard. But the one thing that you haven't mentioned that I would like to put on the table is a disease that you deal with all the time, focal glomerulosclerosis. And that's a disease that we as Black people have more than anybody else. And that's an inflammatory kidney disease. And we now know that there is a genetic influence. And maybe Dr. Melanson, since this is one of your areas of expertise, you might talk a little bit about how you handle your patients pre and post transplant who have FSGS.
Yeah, no, thank you, Dr. Calendar, because you are so correct. And what happens is you focus on the most common causes, and some of these very important. So lupus, FSGS, these things are much more common in the African American community, and they're inflammatory diseases. So that's kind of what you're talking about, Reverend Curry. And the way we handle this, because so many of those patients, unfortunately, will go on to end-stage renal disease. But
Sure.
the treatment is anti-inflammatory. I mean, you're going to give these patients mega doses of steroids, and then they're going to be on chronic anti-inflammatory therapy, the sort of medicines that we give in actual transplant. These are immunosuppressant medicines. One of the things that happens in African American patients is oftentimes we are more prone to these inflammatory sort of responses. Think about it like this. You know that we are more prone to having these hypertrophic scars, like keloids, right? So if you think about our immune system, the same thing is going on inside the blood sometimes. We have a trigger, some sort of trigger, and that trigger causes an avalanche of a response. And
That's helpful.
again, when you start thinking about, well, what's the genesis of all this? Well, again, the theories resound about, infectious diseases. Remember, when you come out of a part of the world where there are lots of deadly infectious diseases, your immune system has to be prone and ready to go. And if you come out of a part of the world like Northern Europe, where it's so cold, particularly right after the ice age, it's so cold that your immune system does not need to be so cat on a hot tin roof ready to go. Then you can see why there might be ethnic differences in how the immune responds.
Absolutely.
So inflammatory reactions in African American patients are an issue. And that's why we see problems that are almost exclusively in Black patients. And Dr. Calendar is alluding to that in these genetic sort of responses. One is HIV. HIV-associated kidney disease is pretty much a Black disease. And again, it's an inflammatory response, right? So why that happens, we're not quite sure. But we know that there's a genetic component. But great point, Dr. Calendar.
So let me throw this in. There's a question that I want to come to in the chat because we're running close on time.
Okay.
are there hereditary factors that are associated with diabetes? Are there factors that make diabetes hereditary? And will you see? I'll go further to say kidney disease to be perhaps even have some genetic uh, associations with it.
Yes, the quick answer is yes. There's no doubt that both of those diseases are inherited, um, through the genetics. However, what I don't want people to understand or to misinterpret is just because you have a predilection in your family, and you can go back and say Aunt Joe and Uncle Bob and my mom and my grandmother, and they all had diabetes, means that I'm prone to get diabetes.
They're not bound to.
Yeah. And that's not because you have this thing called penetrance, right? So just because you have the gene doesn't mean you're going to have the disease. So your behavior is actually more important than your genetics in most of these cases. Now there are certain exceptions, but for the most part, these hereditary diseases like diabetes and kidney disease, it's going to be a mismatch of all these genes that, yes, you definitely have a predilection, but your behavior is much, much, much more important. And that's what people need to realize.
That's important. One question I want to go back, and it says the person says I'm 73, diabetic, high blood pressure, and overweight. A1C is 6.7, CKD 58. What's my life expectancy? How long am I going to live? Yes, sir.
So the good news for that person is they are already at the average life expectancy for America. You said how old? 70 what?
73.
Yeah. So that person is, I would say, should have a normal life expectancy because they're not in end stage renal disease. The worst place to be is diabetic and stage 5, because that's when your mortality really accelerates. So for that person, I would say, you're probably going to have a normal life expectancy. However, you still should be trying to get healthier. Look at Dr. Callender. Dr. Callender's in his mid 80s and looks great, right? And that's because he lives a certain sort of life. So, just because he's already beyond life, he's already outlived it. He's gone past his warranty, right? But he's still alive and looking well. And so now if you were assessing, so he's made it to what, 86, right? So if I'm going to say, well, how long is Dr. Callender going to live? Now, even though normal life expectancy is in the 70s for an African American male, he's now, I would have to say, well, if I'm a betting man, he's going to make it to 90, right? Because he's reset everything because of his diet. He doesn't drink alcohol. He exercises, whatever. I think, do you still do that step like the Alphas did for the show at Howard? Do you still do those steps, Dr. Calvin?
No, but I think your point is well taken, that it's not too late for him to exercise a healthy lifestyle, because as you mentioned, the epigenetic aspect of it is that genes are important, but more important than genes are your lifestyle. And so if at this point you then eliminate or decrease markedly the amount of meat you eat more vegetables, fruits, and recognize that that you can exercise more, meditate more, and drink plenty of water, then there's no telling when your life will end, because you live until you die.
All right. All right. Well, we want to thank Dr. Melancon as well as Dr. Callender for another outstanding kidney talk, these 5 stages of kidney disease. I just thank you so much, and I believe that you have been incredibly helpful when it comes down to sharing this information with those who are tuned in and those that will look at this video on blackdoctors.org in the future. So thank you so very much. Look forward to it. Thank you, my friends, and have a blessed day.